The BMA has changed. We have built the BMA into a machine that delivers strong ballot results and strikes. We have stood up for ourselves at national level. But in many ways, the national pay and GP contract campaigns have enabled a massive growth in local organising, specialty group organisation and equality work. It is the rate card. It is rota challenges. It is the resistance to taking on far more associates in some trusts. It is the GP at hand redundancy dispute. It is the work on sexual harassment in surgery and on racist MHPS systems. We are prioritising work that supports reps, increases visibility, improves representation, and gets to the core of widespread problems. We have overhauled our rep training, and hundreds of you have become active for the first time. To pursue our vision for the BMA, we need change to our local structures too. That's where you come in. We are a diverse profession in who we are and how we work. Many groups now work outside the traditional NHS contracts. To expand BMA support to those who have not been well represented, we need to know the problems. Many of our international colleagues are employed on local contracts, MTI schemes, or in private RMO agencies. Sessional GPs in APMS providers, in digital medicine, and for services like 111 are in a similar boat. Sometimes they have the model contract, but large employers use their dispersed nature to avoid accountability from the BMA or LMCs. We have serious problems with discrimination and harassment in our workplaces, affecting women, disabled members, ethnic minority, religious and LGBT members. Tackling these issues requires the involvement of our full profession and will make space for all to thrive. We are seeking to bolster our support for these groups to fight back. However, so far we've been held back by our local structures. RMOs don't have any bit of the BMA through which they can organise. Dispersed sessional GPs suffer the same problem. We have very limited equality structures. Even LNCs struggle to contact their members to consult them. Why must we prioritise these things? Because doing so makes us strong. We need to build a BMA that can tackle these problems to recruit and keep doctors in membership and in the UK. That means campaigning with RMOs in the private sector, campaigning on fees and visas, focusing on the rights of the locally employed, not just national work, like the free year of membership for international colleagues, but also local work. What do current local structures look like? Divisions are geographical, with all members, student to retired, in each division based on home postcode. This means it is difficult to work with those outside your area. Some active members have put lots of effort into keeping them going, but despite this, the majority of divisions have been unable to have a meeting of 5 people, send a motion or rep to the annual representative meeting, or produce a report in the last 2 years. And that's because the structure has no purpose beyond interacting with the national BMA. There is no organic link to the workplace, meaning many members are underserved by the BMA at work, and there is no link to NHS or political structures such as councils or MP constituencies. The best divisions run as campaign groups, educational meetings and social networking spaces. But fundamentally, those divisions that are doing well and responding to members' local challenges are doing so despite the current structure, not because of it. Doctors and medical students deserve local structures that help us organise. So what could our local structures look like? Following a motion at the annual representative meeting in 2022, Council began consultation from summer 2023 on what structures would help meet these aims. We want our divisions to be primarily the local, well-known face of the BMA, the local arm of our professional association that supports us and acts as a social and supportive network. We want them to be centred around members' workplaces and then their wider communities, including for those who are currently studying or not working. We want divisions to be able to identify and build responses to local issues, including through collective action or directed bargaining, for example, the LNCs. We want them to be able to make policy for the BMA by sending it to ARM and to hold the association to account. We want divisions to be well attended, active, effective and well governed, with lines of accountability and integration into our regional and devolved councils and other regional and national structures, such as the equality structures. We want them to be well resourced, with appropriate staffing and support from BMA centrally and regionally to carry out their roles. And crucially, we need them to be a welcoming place, free from discrimination, where we can have constructive debate based on ideas and not personhood. We got responses in writing and in person at meetings from over 1,000 members, from all branches of practice and all areas of the UK. For the majority of doctors, following this consultation, your division will be determined by who you work for, your trust, your health board, if you're in public health, perhaps a national employer like OHID or UKHSA, the armed forces, your university, an APMS contract holder, an agency or private hospital chain. You might have more than one division, for example if you are an academic or an armed forces doctor or a resident doctor with a lead employer arrangement. This will enable all those who work for the same organisation to work together. It will mean representatives on local negotiating committees can contact you easily and involve you in votes and decisions. It will make it easier for you to improve your own lives. For general practice, both contractors and non-contractors, organising at employer level will make groups of doctors too small. GPs will organise in sensible geographical areas that match the LMCs, counties or NHS structures. This should enable you to access better BMA support for LMCs with the explicit trade union work only the BMA can do, including in areas where sessionals currently feel underrepresented. Those working in public health, occupational medicine, consultancy and other small areas of our profession will group into regional and devolved nations divisions. Retired members will organise in regional, national and smaller geographic areas as fits each area, so that you can have face-to-face meetings to meet professional, social and political needs. Students will organise regionally, so that where placements are shared between medical schools, and perhaps in the future with apprentices, you can work together across medical school lines. You will also work with academics, so that when universities attack teaching and resources, you can fight back together. You will be able to build a structure that serves you. In the devolved nations, employers are often health boards or trusts, which can be large. You and your colleagues will decide how to organise within these. Full details for every circumstance can't be covered in a short video, but more information is in the ARM papers. New combines will enable all of us to access pan-profession discussion, like some current divisions have and benefit from. These groups of divisions will be able to discuss issues that affect all of us, such as regulation, ethics and training. We can also use these groups to address any issues that affect a whole geographical area, like devolved health decisions, local political work or educational work. All of us will be able to access the benefit of varied experience, different types of medicine, ages and so on. Our combines will meet at least twice a year. We have grown a lot by sticking up for ourselves nationally and by organising on the ground. We want to build a BMA where we can bargain proactively to improve our lives, where we solve problems, including hard problems like institutional racism, before our colleagues have their lives affected by them, where members and reps have access to better training to do that work together with staff, where reps are visible at work and we have more power, where our profession shines in the work we do for our colleagues, our patients and our health system, where we represent the full diversity of our profession and where the vast majority of doctors are members. To change our local structures, members need to change the rules that govern the association, the articles and bylaws. The changes will be voted on at the annual representative meeting, or ARM for short, by your elected reps and needs a 2/3 majority. If the changes pass at ARM, you and all BMA members can vote at the AGM for the changes, where they will need a 75% majority. If you are at ARM, vote in favour of the changes, and if you are a member, join the AGM online and vote in favour of the changes there too. Building a structure that works for us locally is just one step of building a better BMA. You need to make that change possible. Join the AGM, vote for change, win together.